changing in cardiovascular health. I have been so impressed by the progress that's been made. And you know, was a little bit of a surprise. These weren't built as drugs to treat people with obesity. Of course, they began as drugs for people with diabetes. But the success has been remarkable. 2 drugs, semaglutide and tirzepatide, proved in the United States for use. This study in particular, the history was this. There was a paper that was published in New England Journal of Medicine by a close colleague of mine, Anya Jastreboff, who is also at Yale. And this is SURMOUNT-1. And this study impressed me quite a bit. In this study, they randomized people to 2.5 of semaglutide and then increasing doses in each of the 3 arms. One of the arms goes to 5, one goes to 10, one goes to 15. And a placebo group at the end. So they have 2-week screening period in it. And this trial, SURMOUNT-1 in New England Journal of Medicine, shows a remarkable effect on weight change. So this figure shows this classic effect that occurred with tirzepatide, where the placebo group loses 2.4% of body weight. But with increasing doses of tirzepatide, there's an average loss within the groups that's much more profound. Again, in groups with obesity, not with diabetes. To get to with 10 and 20, you get 20% sustained weight reduction. But what was also interesting, and this is why I don't think of these as weight loss drugs as much as I think of them as cardiometabolic health promoters. By the way, I take no money from the companies. I consider myself independent. Even I do this study with Lilly investigators because they own the data. They conduct SURMOUNT-1. I didn't get any payment. I only got opportunity to work with the data, which in some ways is a benefit. But I try to maintain this because I'm very enthusiastic about them and I want to be clear of independence. But so this is interesting to me. So hemoglobin A1C goes down. That's no surprise because these drugs have been used for diabetes. But systolic blood pressure drops 8 points. A diastolic drops by 5 points. Total cholesterol, 7.4%. LDL, 8.6%. HDL goes up 8%. Triglycerides drop 31%. So I'm very interested, it turns out, in this systolic blood pressure. Of course, in the main trial, it's reported as a reduction. But I think we can learn more. This is what occurs in the main trial. The systolic blood pressure drops very quickly and stays down. Diastolic blood pressure also goes down. So this led me to approach them and say, I want to understand more about the blood pressure effect in tirzepatide. And like I said, honored to publish this in Heart. One of the best cardiology journals, of course, and we're very fortunate to have the editor here today running this session. So I'm just going to get to the main point. This post hoc analysis demonstrated that 72 weeks of treatment with tirzepatide was associated with consistent reductions in blood pressure, shifting the blood pressure distribution curve to the left, frequently leading to normalization. And I say, I don't even know what normal blood pressure is anymore. Lower seems to be better as people tolerate it. But we said to what have been traditionally in the guidelines considered to be normal blood pressure values in participants with elevated blood pressure with relatively few blood pressure related adverse effects and largely mediated, but not wholly mediated by weight change. So this is a group just to show you the demographics. The average age in the 40s, mid 40s, and 67, 67% are women. There is some variation in the background, racial or ethnic group. Asian, for the purpose of this meeting, 10% Asian. And most people had had obesity for many years, 14 years. And their body weight was quite high, the kilograms, quite high, 104, with a BMI of 37, 38, quite high. And the systolic blood pressure, so it's important to say we excluded people with very high levels of blood pressure. So the average blood pressure in the study is not elevated. 123 systolic, 180 diastolic. So this is a question, what's the blood pressure effect in the group? Some people have hypertension, but not Stage 3, only stage 2. So this is what we look at. The top is what you saw from the trial. It just really replicates the overall finding, but we're interested in the distribution. What happens here? Why does the blood pressure go down? Is it very few people who are experiencing large-scale change, or is it relatively a large effect in the entire group? What you see in the density plots at the bottom is a shifting. This is what I mentioned, the shifting of the curve. So basically you take the whole distribution of blood pressure, it goes to lower. It goes to lower. And almost everyone experiences this decline. So it's really this rapid decline, which, by the way, precedes some of the weight loss. But people are almost immediately experiencing the antihypertensive effects of tirzepatide, both in systolic and diastolic, over the first 24 weeks. And then it stabilizes. I find this so interesting because it's almost as if the body is enabling the drug to have an effect of lowering, but it doesn't take you too low. It's almost like the weight effect also. You lose the weight, but people don't become anorexic. They don't become too thin. It equilibrates at a certain level. And this is quite interesting. What we did here, which wasn't in the main article also, was subgroup analysis. Is this experience of antihypertensive effect sequestered in certain patients, or is it a broad scale effect? We look at systolic in the top, diastolic in the bottom, in these forest plots. Hard to see, but you can get a sense of the pattern. You start looking at all of the different subgroups, and they're all experiencing consistent reductions. The one exception are people on hypertensive medication. Now, the one thing they didn't do in SURMOUNT was to evaluate the use of antihypertensive medications very closely. So that loses the opportunity to see what happened with the medication. What I suspect happened was, with medication, they're changing the doses of medication to maintain the blood pressure that they're seeking to achieve. So they're blunting the overall effect of tirzepatide on blood pressure. If you look at the people not on blood pressure meds, you're seeing a very consistent effect as you are with everyone else. But on the smaller group of people on blood pressure meds, probably their doctors are changing the meds all the time during the trial in order to keep them. That's what I suspect is happening. So here is another important finding of the study. Now, again, my feeling is, in general, we continue to find in the intensive blood pressure trials that lower is better as long as people tolerate it. So, whether or not these are useful categories or not, it's something we could debate. But they're found in the guidelines. We talk about them all the time. I never like this word normal. There is no normal. But this is what the guidelines say. So if you look at baseline for placebo, and then we pooled the tirzepatide groups, we pooled them together. The green represents the people in this normal stage according to guidelines. The yellow is elevated, then the orange is stage 1 hypertension, red is stage 2 hypertension. As I told you, the trial didn't include people with higher than that blood pressure, and there weren't so many people with stage 2. But actually, if you look overall as considered hypertensive, it's about half in the groups at baseline. So what happens at 72 weeks? The number of people labeled normal goes up slightly in the placebo group. The elevated is about the same. The stage 1 slightly smaller. The stage 2 is about the same. You look in the tirzepatide group, the normal blood pressure goes from 30 to 58. Almost doubles the number of people with normal. Elevated stays the same, but again, those are a lot of people coming down, and now they're elevated. The stage 1 goes from 40 to 23, and the stage 2 goes from 15 to 6.5. So this becomes a remarkable effect. We did a mediation analysis. To what extent is the weight loss explaining the change in blood pressure? And this is very interesting to me. I see it in two ways. So weight loss was estimated to explain 67.6% of the systolic reduction and 71% of the diastolic. There's a significant but moderate correlation between the body weight and systolic blood pressure. When you look at the individual level, and I'll tell you how I interpret this. Okay, weight loss is explaining most of it, but at an individual level, it's not. So that part of that may be the noise of blood pressure measurement itself. It's not such a precise thing. We've written about this in other studies. But there's also, even in the mediation analysis, maybe 30% is not explained by weight loss. You know, sometimes people talk about blood pressure as being inflammatory disease too. We know these drugs are anti-inflammatory. I don't know exactly what's going on. The question is it all about weight loss? Are there other effects of these drugs? It's interesting to speculate. There should be much more research going on, but like I said, I was drawn to this because I think it's a frontier for us to think about this. How about severe and serious treatment emergent adverse effects? You know, in these trials, FDA requires very stringent approach to evaluating these adverse effects. So, you know, there's many things going on for these patients, of course. But if you think about the blood pressure, adverse effects occur in only 4 participants in the pooled group. We're looking at adverse effects associated with hypertension, you know, ones that we might have expected. Hypotension, syncope, pre-syncope, loss of consciousness. It's not happening to any great extent. So even though the group is starting at an average of 123 and we're dropping them a net of 8, we're really not seeing adverse effects in the group as a result. There are no reports of severe orthostatic hypotension in either group. Again, I'm intrigued. I mean, I wouldn't use this drug to treat hypertension in the vast majority because they're already considered normal. But in this trial, it's giving us a lot of clues about this. So what are the caveats? Not a study of people with hypertension. This wasn't a study, but there are ones being done. And it lacked information on changes in the hypertension medications, as I noted. But here's what I'm intrigued by. Maybe the best way to treat hypertension in people with obesity is to treat the obesity. So I wonder if many of the patients I'm seeing in clinic who have obesity and hypertension, we're going after the manifestations of the obesity. We're chasing them with antihypertensive medications. But for many of these individuals, we can actually bring them down to normal or elevated levels just with treating the obesity itself. Now, in China, these drugs are more affordable than US. In the US, we have access problems for these drugs. But I wonder if in the next decade, we are going to be thinking about obesity in very different ways. And it's going to be a very effective approach for hypertension. I'll just say one final thing. You look at the hypertension trials, you don't actually see such a large decline in general as we saw in treating the obesity in SURMOUNT-1. So I'm very eager to see in these upcoming trials of all of these agents, and you know that there are many agents in the pipeline. What happens with hypertension? I wanted to just end by saying there also was from SURMOUNT, some patients enrolled from China. This was published in JAMA, Tirzepatide for weight reduction in Chinese adults with obesity. Of course, it's a smaller group, but there was no evidence that there was less impact among people in China. Different context, different background, so forth, different diet, but still same effect. 谢谢。